Be talking, reviewing the NRP and also the new update of the 8th edition, the changes in the NRP. So we have our policy in place, and you can see that. Oops. Oh, no comment. So you can see that the purpose here is 10% of babies need some help, 1% of help, and then when we do resuscitation, we have to anticipate the resuscitation. We're doing training as usual, and you know the NRP has to be validated every 2 to 3 years. How we anticipate resuscitation when we're looking for high-risk deliveries. And high-risk deliveries, these are maternal condition, fetal condition, and complication during delivery, okay, and also during immediately before delivery, so these are the list that you guys need to be aware of, and we know the definition of the preterm babies is more like held than term babies, and preterm babies, any babies less than 37 weeks, and there are 3 types. Late prematurity, prematurity, and extreme prematurity. What are the challenges that preterm baby are exposed? It's hypothermia, improper ventilation. Also, they're prone to infection, organ damage, especially the eyes, or during the PPV, or also the lung during PPV. We do lines, skin, they can be damaged. These babies, we need to do antenatal counseling, and this antenatal, we talk with the parent what is the challenges of the baby, the duration of stay, when they go home, what they exactly need to expect, what their chance of staying alive, what is the complications, and so on. Here is one of the changes that is expected, is not showing here. So the questions that is, I don't know what is not showing. No. So these are the changes. That's one of the changes. So the question, is this baby full-time? Now the question is, what is the gestational age? Instead, is the baby full-time? Is amniotic fluid clear? The question was already there, but it is moved up. And the other question is there is any risk factors? Or absence of risk factor? And the other now is including umbilical care management plan should be mentioned with all babies. So how we will do delay cord clamping, what's the duration, and how we cut the cord, and how we use assembling. So umbilical cord management plan are added in the new edition. So the all the difference are same, but the umbilical management plan should be discussed, and delay cord clamping should be tried for at least 30 seconds minimum. Okay. The other changes that happening to this baby or to the NRP is that before they said that the suction if necessary. Now everything if necessary. So provide warmth, dry, stimulate. Position airway was not there. So now it's part of the first initial stabilization. The positioning of airways was not there. And suctioning, all if necessary. So you don't need to dry if the baby already dry. You don't need to provide warmth if the baby the temperature is okay. So all if necessary. You need to do all or not, depending on your assessment. The other step is after that, the breathing, the chest compression are the same, no changes. Further resuscitation and the step of resuscitation are all there, no changes. Okay? So these initial step in details now, the warmth, the positioning, the drying, the stimulation, and the type of stimulation, provide aggressive or not, turning the baby is not acceptable, the head that is always should be supported, and the baby need not to be upside down, need to be flat, be safe and appropriate stimulation. It's slapping or flicking the sole, wrapping the bag, and it's up and down. And more vigorous stimulation is not helpful. No need to be flat. Okay, and then we have the routine care. That means the baby stay with mom. So they changed the algorithm. Now they are recommending the baby should not move outside the room of the mother if it's routine care. So you will see that they changed the algorithm, the first initial algorithm. Okay, so they are not allowed officially from the NRP. Babies cannot be moved for any routine care, circumcision, injections, vaccination, screening, cleaning, bathing, all should be with the mother. But if baby required further management, is intermediate care. Okay, and there's also another changes now with the ECG. So previously was Elikitron may be a reasonable option to provide more rapid and accurate estimation of neonatal care in the delivery room. So now they've changed the statement. It said now, when an alternative airway becomes necessary. Okay, when an alternative airway becomes necessary, a cardiac monitor is recommended for most accurate assessment of baby's heart. So they've changed it that put electro, ECG monitor only if you need to do active resuscitation. Okay, so they moved it only if you need an alternative airways, which means if they do PPV and baby is okay, then you need a cardiac monitor. If you need to put an airway, if you want to put CPAP, all the babies need to be pulse oximetry. Unfortunately, we don't have pulse oximetry, but it's coming. We are only using cardiac monitor or ECG monitor. The rest is what you do when the heart rate below 100, the same, no changes. And when the baby is labored breathing and the rate is more than 100, no changes, same. So you need to give oxygen or try CPAP. For preterm babies, controlling temperature is the same, no changes. Skin to skin or polyurethane bag or warming pads are all same, no changes. Airway management are the same, no changes. Meconium stain, still recommendation not to suction the trachea. Pulse oximetry should be done in the same way. The target oxygenation are the same. However, they added two things. I need to change this. They added two things that here they added when the baby is more than 35 weeks, start with room air, and when the baby less than 35 weeks, start between 21 and 30%. Before they say less than 35 weeks, 30%. Now they said it's, you can see that it's 21% when 35. When baby less than 5, it's between. You decide how much. The lower the gestation, the more the concentration. Of course, when you start chest compression, you need 100%. When you provide positive pressure ventilation, if the baby is less than 100, when the baby is less than 60, you need chest compression and PPV. When less than 60, when less than 100, you need only airways. And the rest is the same. The oxygen concentration and the details of that, no changes. The use of TPs, resuscitate, use of LMA are all the same, no changes. Initial breath provision, no changes. The numbers, the type, provision of CPAP, it's now recommended. All babies deserve a trial of CPAP. Now, if you have a variable flow CPAP, that would be great. If not, you can use the constant CPAP through a mask, by self-inflation or flow inflation, by flow inflation mainly, but also you can use the TPs and also the neopuff. And the indication of intubation, no changes, the same. The procedure of intubation, no changes, but now the recommendation to use the video laryngoscope, not the laryngoscope, for people who now will see if the tube is going with you outside in the monitor, whether the tube is going to the airways or not. And so it's better for being absolutely sure that you are correctly intubating the trachea, and also for learning. So if a trainee are intubating, I can see whether they are in the, so laryngotomy is now advised, if possible, of course. Chest compression, the two-thumb technique are preferred. So two-finger technique are preferred, not the one-hand technique. Epinephrine has been changed. So you can see that the suggested initial dose, whether IV or intraosseous, is now 0.02, not 0.1 to 0.03. You see, previously was this.
Yes.
Now they've changed it
To
to 0.02, and it's a fixed dose.
Yes.
Okay, of 1 in 10.
Yeah, and regardless of the gestation also, doctor.
What do you mean?
Yeah, it's regardless of the gestation.
Regardless of the gestation,
Yeah.
it's per kg.
Yes, it's,
Yeah.
that one is the standard dose.
Standard dose.
regardless of
And
the
also they
gestation.
remove the range
Yeah.
from the ATT.
Yeah.
So they make it 0.1. Okay, 0.1 milligram, very high dose, you know. You can see. Previously was a range from 0.05 to 0.1.
Yeah.
So
This
that's
one
they
is
change
1
it.
ml.
Volume expansion indication, no changes. The non-recommended drugs such as naloxone or bicarb is the same. Failure of resuscitation has been changed. So what they did now, they said that the resuscitation effort may be discontinued after 20 minutes. Before it was 10 minutes. And if confirmed absence of heart rate after all appropriate resuscitations are performed. So what do you mean that? You are giving effective ventilation, you are doing chest compression, and you're giving medications. If you did that, and after 20 minutes of that, effective ventilation, chest compression, medications, after 20 minutes, you can say that resuscitation is stopped. Before it was 10 minutes. And the reason for that, because they found the complications after finishing at 20 and 10, there is no difference. So that's mean we'll give the baby, because previously thought that if you continue after 10 minutes, you will have babies with serious complications, anoxia and complications, and maybe handicapped and major complications. But they found that if you do it for 20 minutes or 10 minutes, there is no difference of the complication. But the 20 minutes will give more chance for the baby to survive. So that's why they moved to 20 minutes instead of 10 minutes. Okay? However, decision individualized based on the patient and the contextual situation. So withholding resuscitation, same, no changes, depending, if baby is less than 23 weeks or less than 400. So if the baby is more than 400 or more than 23 weeks, they deserve a trial of resuscitation. And the best is to resuscitate, move the baby to an ICU, connect to the ventilator, and then decide. As in UAE, we don't have a withdrawal of support. All the babies deserve resuscitation. So post-resuscitation measure, hyperthermia, hypoglycemia, apnea, seizures, pulmonary complication, hypotension, electrolyte are all signs. Checklist and timing, same, no changes. So I will move, these are the references that we took the guideline from. The list of equipment, same, no changes. These are the list of the equipment, if you guys are aware of it. The list of complication, fetal complication during birth, the list of high risk is still there. This has been changed. Okay, so you can see here now, staying with mother. If time or good tone and breathing or crying, stay with mother, no change. This is very important. And also there's change here. You see that now they add initial oxygen concentration, they put it in the graph. It was not in the graph before. So it being more than 35 weeks, you need 21%. If less than 35 weeks, from 21 to 30, this is another change. Okay? And the duration and timing of intubation and other are the same, no change. This is the correct position, are the same, no changes. The placement of the umbilical catheter in emergency situation as low lying, no changes. How to fix, no changes. How to give PPV, the C and E shape, no changes. The size of the diameter of the ATT with the gestation, no changes. The insertion length, no changes of the ATT, and according to the weight and gestation, no changes. The two thumb technique, the way we do it is a preferred, no changes in how to do it. One hand technique, no changes, the same principle. The medication, the epinephrine, this one is being changed. So I need to change this diagram.
Yes,
Okay?
doctor.
This has been changed in here.
Point,
Yeah.
point 2 now.
Yeah. But this one is, yeah, so it should be always point 02. Okay. So this is Nidajan. The checklist is the same. Pre-delivery checklist, if you guys know that we have it. When it's red, when it's yellow, it's for very small babies. Extreme, which is less than 27 weeks. So you can see the nursing, and of course this will be true of you because we don't have RT. And you can see that the physician have no chest for premature babies. When the delivery is imminent, there is another checklist. So we have this, and you can see at 15 minutes we have a checklist for each gestation. 30 minutes, 60 minutes, we have a checklist. When 2 hours, we have another checklist. We have a transport checklist, so you need to remember that always when you do the checklist. Immediate resuscitations, we have a checklist, and we have timing, how to do procedures. So you can see the timing is the same. So we are expecting delay cord declamping and CPAP within first 2 minutes. We're expecting dextrose to receive the baby by 10 minutes, and you can expect the caffeine hit the baby by 20 minutes. The central line should be within, or peripheral, within 45 minutes. And the sepsis workup, within, you can see from birth till 2 hours. And you can see the surfactant still not an emergency. So you can give surfactant somewhere after 30 minutes. The reason is because we need to achieve functional residual capacity, good inflation before we give surfactant. Debriefing, same, no changes. This is another policy I have to move. I think this is the policy about hypoglycemia. Yeah, this is about hypoglycemia. I think I'm done. Any question?
No, doctor.
Okay. So did you record it?